Imagine deliberately taking a wrecking ball to the outside of your house, right? Just to force the neighborhood construction crew to show up and build you a stronger roof.
Right.
Because that is exactly what you are doing to your face every single time you get a laser skin treatment.
Yeah, that's exactly it. That sounds crazy when you put it like that.
It really does.
Yeah.
But today, we're kind of bypassing all that slick cosmetic marketing, and we're diving deep into the actual biology of your largest organ, which is your skin. So, welcome to the deep dive.
Thanks for having me.
If you're listening to this, you're probably someone who, wants to get thoroughly informed without drowning in all that heavy medical jargon.
Yeah.
You definitely want to know how things actually work under the surface.
And, the skin is often just thought of as this static wrapper, like a packaging for our bodies.
Right, it's holding everything in.
Exactly. But it's actually an incredibly dynamic, communicative organ. I mean, it's a barrier, sure, but it's also a highly sensitive environmental sensor.
Yeah.
And it's a biological canvas that really reflects our internal chemical health. So today, we are going to unpack how your skin responds to controlled trauma and how your hormones dictate its structural architecture.
Which is fascinating.
It is. And critically, we'll talk about how to decode the signals it sends when a sort of aesthetic annoyance crosses the line into a serious medical red flag.
Yeah, and rather than just reading off a boring syllabus, we're going to pull from a whole stack of sources as we go.
Right.
We've got clinical prep guidelines from Etri Cosmetic Dermatology and the Center for Dermatology. We're pulling clinical insights on melasma from Dr. House Dermatology, a really fascinating December 2025 article from the American Society of Plastic Surgeons.
That one is so interesting.
It really is. Plus, a retrospective study from PubMed on healing and an official NHS primary care pathway for skin cancer. So, a lot to cover.
A lot of ground, yeah.
But if we really want to understand how skin regenerates, we have to start by looking at how modern dermatology essentially forces the skin to rebuild itself through laser resurfacing.
Right, the wrecking ball approach.
Exactly. So looking at the actual clinical prep guidelines, they outline how lasers use these short, really highly concentrated pulsating beams of light to remove irregular outer layers of skin.
Yeah.
And the goal here is treating hyperpigmentation, deep-pitted acne scars, lines, wrinkles, you name it.
Well, and it's a highly invasive procedure when you really look at the biology.
Really? Like even the non-surgical ones?
Oh, definitely. You are utilizing focused light energy to literally vaporize the water inside the skin cells.
Wow.
Yeah, essentially destroying the targeted tissue. By creating this controlled burn, you are deliberately traumatizing the skin to trigger the body's acute wound healing cascade.
So you're tricking the body into thinking it's severely injured.
Exactly. When the skin's surveillance system senses that thermal damage, it sends out these massive chemical distress signals. And that wakes up your fibroblasts. Yeah, those are the specialized cells responsible for generating connective tissue. So it wakes them up and forces them to synthesize brand new, tightly woven collagen and elastin fibers to repair the damage.
Okay, which completely explains why the prep protocols in these clinic guidelines are so intense.
Oh, they're strict for a reason.
Right, like you have to stop all retinoids, glycolic, salicylic, or lactic acids 5 days before treatment. You can't have any direct sun exposure for 2 weeks.
Yeah.
You even have to stop common blood thinners. Like, they specifically say no aspirin, ibuprofen, vitamin E, or fish oils.
The underlying biology here is really all about managing variables. So take the exfoliating acids like glycolic or salicylic acid.
The ones people use every day in their skincare routine.
Right. They work by dissolving the bonds between dead skin cells. If you use them right before a laser treatment, you've artificially thinned the skin's protective barrier, which is the stratum corneum.
So you've already taken down the first line of defense.
Exactly. Because the barrier is compromised, that laser energy will penetrate significantly deeper than the clinician intended.
Oh, wow.
Yeah, so you turn a very precise, controlled demolition into just uncontrolled devastation. You're risking severe burns and permanent scarring.
That is terrifying.
Yeah.
Okay, but what about the rule about fish oils and aspirin? Why does my blood matter if you're burning my skin?
Because the laser delivers such intense thermal energy, it actually impacts the microvasculature.
The microvasculature.
Yeah, the tiny capillary blood vessels that feed your skin. If your blood is artificially thinned out by, say, a daily aspirin or high doses of fish oil, the normal clotting mechanism is delayed.
Oh, I see where this is going.
Yeah, those damaged capillaries will leak way more blood into the surrounding tissue, so that leads to massive bruising and a highly prolonged, very complicated recovery.
So you're just bleeding under the surface. That makes total sense. And the post-care rules are just as strict.
Extremely.
The Center for Dermatology guidelines emphasize absolutely no picking at the flaking skin, which I know is so hard for people.
It is, but it's crucial.
You're instructed to use cool compresses, broad-spectrum SPF 30 or higher, and these thick, hydrating moisturizers packed with hyaluronic acid, aloe, or ceramides.
Think back to your house analogy. You've just ripped the roof off.
Right.
Until the construction crew finishes the new one, you have to artificially protect the interior of the house. So ceramides are lipids, basically fats, that naturally occur in the skin.
Okay.
They act like the mortar between the bricks of your skin cells, sealing moisture in and keeping bacteria out.
That makes sense.
And by applying topical ceramides and hyaluronic acid, which, by the way, holds like 1,000 times its weight in water.
1,000 times.
Yeah,
Okay.
it's incredible. You are creating an artificial temporary barrier. This lets those fibroblasts do their rebuilding work in a hydrated, protected environment.
Okay, so lasers are this incredibly aggressive physical solution for surface issues. But what happens when the pigmentation you're trying to blast away isn't just a surface stain?
Right, when the cause is internal.
Exactly. Like, what if the call is coming from inside the house, driven by internal chemical signals?
That's when we have to move from physical architecture to chemical messengers. And a prime example from the clinical literature here is melasma.
Yes.
Dr. House Dermatology actually provides some really extensive clinical insights on this.
Right, melasma or chloasma. It presents as these symmetrical tan or brown patches, typically on the cheeks, the bridge of the nose, forehead, and chin.
It's very distinctive.
And it is so common in pregnant women that it's widely referred to as the mask of pregnancy.
Yeah, and the interesting thing about melasma is that it requires a very specific dual trigger mechanism.
Dual trigger. Like two things have to happen at once.
Exactly. It is driven primarily by internal hormonal fluctuations. So pregnancy, birth control pills, hormone replacement therapy, or even thyroid dysfunction.
Sure.
But here's the catch. Having elevated estrogen or progesterone doesn't automatically create those dark patches on its own.
Oh, really?
No, the hyperpigmentation is only activated when those internal hormonal shifts are exposed to an external catalyst, which is ultraviolet radiation from the sun.
Okay, so you need the hormones and the sun.
Yes.
Which leads to my next question. Because the treatments range from topical creams like kojic acid and hydroquinone, which Dr. House notes actually suppress the skin's melanin production, to specific medical lasers like Fraxel and erbium.
Right.
But wait, hold on. If melasma is triggered by light radiation from the sun, how does blasting the face with highly concentrated laser light not just, pour gasoline on the fire?
I love that you brought this up. You've hit on the biggest paradox in laser dermatology.
It just seems completely counterintuitive to me.
It does. Until you look at how melanocytes, which are the pigment-producing factories in the lower levels of your epidermis, how they actually respond to different types of light.
Okay, break that down for me.
Sure. When you walk out into the sun, broad-spectrum UV rays hit your skin. The skin cells interpret this UV radiation as cellular damage, so they release a widespread chemical alarm.
Like an SOS.
Exactly. That alarm tells the melanocytes to start producing melanosomes, which are these little packets of pigment.
Right.
And they push them up to the surface like tiny umbrellas. They literally do this to shield the DNA of the surrounding cells from further radiation.
So broad-spectrum sunlight acts like a blaring, building-wide fire alarm. Everybody panic, put up the umbrellas.
Yes, exactly. But medical lasers operate on this principle called selective photothermolysis.
Selective photothermolysis. That's a mouthful.
It is, but it basically means they use a very specific isolated wavelength of light that is only absorbed by the dark pigment itself.
Oh.
Yeah, so the surrounding clear skin cells virtually ignore it. It's less like firing a shotgun into a room and more like an opera singer hitting a perfectly pitched note that shatters one specific crystal glass while leaving the windows and all the china completely untouched.
Wow, that is a great analogy. That makes so much sense. So the laser energy shatters the existing clumps of melanin into microscopic particles. And then the body's immune system, I think the source has mentioned scavenger cells called macrophages. They can just sweep it away. And it does all of this without triggering that general fire alarm that wakes up the melanocytes.
You nailed it, though I will say the clinic notes are very clear on this next part. If you walk outside after that laser treatment without strict, broad-spectrum SPF protection, the sun will simply ring the fire alarm again.
Because you haven't fixed the root cause.
Right. The laser destroys the existing pigment, but it does absolutely nothing to cure the underlying hormonal sensitivity that caused it in the first place.
Which brings us to a massive shift in how the medical community is thinking about skin biology right now. And this was detailed in that really fascinating December 2025 article from the American Society of Plastic Surgeons.
This is such a game changer.
It really is. Because we just established that hormones like estrogen can trigger hyperpigmentation. But the loss of those hormones severely alters the skin's structural integrity.
Absolutely.
So we're moving from just treating aesthetic symptoms to actually replacing the root biological signals.
Well, and for decades, you have to remember, the entire anti-aging industry has been focused on external fixes.
Right, creams and serums.
Yeah, or paralyzing muscles with Botox,
Yep.
or chemically burning the skin like we just talked about to force repair. But when systemic estrogen levels drop during perimenopause and menopause, the physical scaffolding of the skin just collapses.
The numbers in the ASPS article are honestly alarming.
Yeah.
They note that women can lose up to 30% of their dermal collagen in just the first 5 years of menopause alone.
30%. That's huge.
Right. And then it continues to drop by another 2% every single year after that.
We really have to understand estrogen's role beyond just reproduction. In the skin, estrogen is like the master conductor.
Okay, how so?
So those fibroblasts we talked about earlier, the collagen factories,
Yeah.
they have specific estrogen receptors on their cell walls. When estrogen binds to those receptors, it upregulates the gene expression that literally tells the cell to manufacture collagen.
Oh.
It also promotes the production of hyaluronic acid to keep the skin plump, and it maintains that lipid barrier we mentioned.
So it's doing everything.
It really is. So when systemic estrogen drops, those receptors are basically starved. The instruction manual is suddenly totally blank. The orchestra stops playing, and the skin rapidly thins, dries out, and loses its elasticity.
So the medical breakthrough they're talking about here is estrogen-based skincare.
Exactly.
These are prescription topical products using bioidentical estrogens. They use either estradiol, which is the stronger one, or estriol, which is a weaker mimicking compound.
Well,
And they are formulated to penetrate the outer barrier and bind directly to the estrogen receptors in the skin.
Yes. You are delivering the hormone locally, directly to the tissue on the face and neck that is completely starved for the signal. And you're doing it without having to take a systemic pill that affects the rest of your body.
Which is incredible. If you think about the hundreds, honestly, thousands of dollars people spend on traditional skincare, it really puts this into perspective.
It really exposes the limits of over-the-counter products.
Like heavy moisturizers just sit on the surface, trapping water until you wash your face. It's like putting a bucket under a leaky roof.
That's a perfect way to look at it.
Right. And retinoids, they work by irritating the skin to force it into a mild repair state. But applying topical estrogen is actually patching the hole in the roof by restoring the original biological signal that kept the roof intact in the first place.
It really is a fundamental shift from forced trauma to biological restoration. But, and this is a big but, applying a hormone directly to the face does carry risks.
Yeah, the ASPS article notes that.
Right. They point out that estradiol, the stronger variant we mentioned, can cause local side effects. It can trigger hormonal acne along the jawline, cause local skin irritation, and ironically, it can actually trigger hyperpigmentation.
Because, as we literally just discussed with melasma, estrogen wakes up the pigment-producing melanocytes.
Exactly. It's a very delicate biological tightrope you have to walk. This is why a lot of dermatologists actually prefer prescribing formulations with estriol.
The weaker one.
Right, because it's a weaker compound, it still provides the signal to the fibroblasts to boost collagen and hydration, but it doesn't bind as aggressively. So it significantly lowers the risk of waking up the melanocytes or triggering acne.
Okay, so we have these two sort of competing concepts here. Lasers cause massive thermal trauma to force the skin to rebuild.
Yes.
And estrogen is the master chemical conductor that gives the skin the instructions to rebuild.
Right.
So the obvious question, if you're putting this all together, is what happens when you combine them? Like, if having systemic estrogen in your body builds collagen, does it help you heal faster from a massive laser burn?
You would intuitively think so, wouldn't you? Like, Pumping the body full of the very hormone responsible for skin health right before a major resurfacing procedure would be the ultimate hack for accelerated healing.
Right. So a team of researchers actually asked that exact question in a retrospective study published in PubMed by Batra et al. In 2003.
Yeah, it's a very famous study.
They analyzed 44 female patients who underwent full-face combination CO2 and erbium laser resurfacing, which, as we've established, is about as heavy-duty as a cosmetic procedure gets.
It's a major trauma to the face.
Yeah. And they compared patients who were taking exogenous estrogen, like hormone replacement therapy or oral contraceptives, to a strictly matched control group of women who were not taking hormones.
And they matched them for age, skin type, and the specific laser energy used, which is a very robust methodology for isolating the hormone variable.
Very thorough.
Yeah.
But the results completely contradict what you'd intuitively expect.
They really do.
Exogenous estrogen did not alter the postoperative progress at all, like zero. There was absolutely no statistically significant difference in erythema, which is the intense redness, swelling, crusting, or the rate of reepithelialization between premenopausal women, postmenopausal women, or women taking hormone replacements.
And just to clarify for everyone listening, the term reepithelialization simply means the process of the epidermis literally growing new skin cells to cover the open wound. The fact that systemic estrogen didn't speed this up reveals a profound truth about how the human body categorizes damage.
So why didn't the master conductor help rebuild the house here?
Well, because the body operates with different physiological gears.
Okay.
Estrogen governs daily, long-term skin maintenance. It regulates the slow, steady retention of collagen over decades. Think of that as first gear.
Okay, just cruising along.
Right. But a third-degree laser burn is an acute, catastrophic injury. When the body senses that extreme level of tissue trauma, it abandons first gear entirely and slams into fifth gear.
Oh, wow.
It activates an emergency, localized wound healing pathway.
So what does that fifth gear actually look like at the cellular level?
It's an immediate flood of immune cells. Platelets rush in to stop the bleeding. Macrophages arrive to swallow up dead tissue and bacteria.
The cleanup crew.
Exactly. And most importantly, the damaged cells release massive amounts of acute inflammatory cytokines.
Cytokines.
Yeah, they're chemical messengers that essentially scream for emergency repair. That localized cytokine alarm completely overrides the slow background hormonal baseline.
So in a crisis, the skin simply doesn't care about your estrogen levels. The local emergency response team just takes total control of the site.
Exactly. Whether you are 30 years old with peak estrogen levels or 65 with virtually no estrogen, your immune system's emergency repair crew operates on the exact same timeline when faced with acute thermal trauma.
That is wild. Okay, so we've spent a lot of time talking about manipulating the skin for aesthetic reasons. You know, intentionally burning it with lasers, fighting off melasma, using hormones to retain collagen.
The vanity side of things, yeah.
Exactly. But because the skin is our outer shield, it is subjected to a lifetime of invisible, mutating radiation from the sun. We really have to know how to identify when the damage isn't just cosmetic aging, but an active threat.
Absolutely. This requires shifting our mindset from aesthetic dermatology to oncology.
Right. And the NHS Southeast London guidelines provide a really comprehensive primary care pathway for identifying skin cancer.
They do, and it's crucial to understand why these different cancers look the way they do based on which specific cells the UV radiation has mutated.
Let's walk through the clinical profiles in those NHS guidelines. They start with actinic keratoses, or AKs.
Yes.
Now, these aren't technically cancer yet, right? They are precancerous, rough, quote, sandpaper-like scaly patches that usually appear on the scalp, face, or back of the hands.
Exactly. And actinic keratosis is a visible marker of localized immune failure.
Immune failure.
Well, the UV radiation has damaged the DNA of the keratinocytes, which are the primary cells in the outer layer of your skin. Because the DNA is damaged, the cells don't shed normally like they're supposed to. Instead, they rapidly multiply and stack up on top of each other, creating that hard, rough keratin scale. The guidelines note they are typically treated with topical chemotherapy creams like Effutix, which contains Fluorosil.
Wait, how does a topical cream clear a precancerous mutation? Like, how does it know which cells to attack?
That's the brilliant part. Fluorosil targets rapidly dividing cells. It basically interferes with their ability to synthesize DNA.
Oh, wow.
Yeah. The cream essentially starves the mutated cells, causing them to die and slow off, while largely sparing the healthy, slower dividing cells around them.
That's amazing. Okay, then the guidelines move to actual carcinomas.
Yeah.
Basal cell carcinoma, or BCC, It's described as a slow-growing, pearly, translucent nodule.
Yeah, that pearly look is key.
And it often has an ulcerated center and visible tiny blood vessels, which the medical literature calls telangiectasia.
Right. And the visual presentation tells you exactly what is happening under the surface here. BCC originates in the basal cells, which are at the very bottom of the epidermis.
Okay.
Because these cells are deeper, the tumor grows as a smooth, shiny, pearly bump rather than a rough scale like the AKs. The telangiectasia, those tiny spider vein blood vessels on the surface, are visible because the tumor is actually recruiting its own blood supply to feed its slow growth.
It's literally building its own life support.
Exactly.
Creepy. Then there is squamous cell carcinoma, or SCC. This presents as a scaly, crusted, non-healing nodule or ulcer. And the guidelines note this is particularly dangerous for people who are immunosuppressed.
Yes, because SCC arises from the squamous cells higher up in the epidermis. Unlike a BCC, an SCC is highly invasive. It destroys the surrounding tissue as it grows, which is why it often presents as an open, crusted sore that just refuses to heal.
And finally, there's melanoma, which is notoriously the most dangerous.
Mm-hmm.
This is a cancer of the melanocytes, those exact same pigment-producing cells we talked about earlier with melasma.
Right, the umbrella factories.
Exactly. We track this using the classic ABCDE checklist. Asymmetry, border irregularity, color variation, a diameter over 6 millimeters, and evolving.
Yes, but the NHS also uses a specific 7-point checklist for general practitioners.
Right.
And that 7-point checklist is weighted. So the major features, which score 2 points each, are a change in the size of the lesion, an irregular shape, or an irregular color. The minor features scoring 1 point include a diameter over 7 millimeters, local inflammation, oozing or crusting, and any change in sensation. If a lesion scores 3 points or more, it triggers an urgent referral.
Okay, let me ask the practical question for anyone listening right now who might be, checking a spot on their arm as we speak.
Sure.
An actinic keratosis is scaly and rough. A dangerous squamous cell carcinoma is also scaly and crusted.
Right.
How is the average person supposed to differentiate between just a stubborn precancerous sunspot and an invasive dangerous carcinoma without having a medical degree or getting a biopsy?
It's a great question, and the NHS guidelines focus heavily on behavior and sensation. A standard precancerous AK is dry and rough, but it is fundamentally static. It just sits there.
Okay.
The red flag really goes up when the behavior changes. If a scaly lesion starts rapidly expanding over a matter of weeks, if it spontaneously bleeds when you just dry off with a towel, or if it forms an ulcer that will not heal. Or, and this is crucially important, if it becomes tender and painful to palpation, meaning it actually hurts when you press on it.
So sensation is the dividing line.
Exactly. A sudden onset of pain or tenderness signals that the lesion is no longer just sitting on the surface. It means the mutated cells are invading deeper tissues, they're impinging on nerve endings, or they're outgrowing their local blood supply and causing tissue death.
That makes total sense.
When a spot becomes painful, rapidly grows, or bleeds, it crosses the line from a routine cosmetic issue your doctor might just freeze off with liquid nitrogen to an urgent 2-week wait cancer referral.
So the skin is constantly trying to communicate its status to us. We just have to know how to read the physical signs.
Precisely. And understanding the why behind your skin's behavior strips away a lot of the anxiety and honestly the marketing hype.
Yeah.
Whether you are prepping for the intense physical trauma of a cosmetic laser, navigating the structural changes of declining hormones in perimenopause, or just doing a monthly mole check in the mirror, knowing the underlying biology gives you the power to make informed medical choices.
Well, we've covered the entire spectrum today, from the physical to the chemical. We've seen that the skin responds dramatically to external trauma, to long-term radiation from the sun, and to internal chemical messengers like estrogen.
It's a busy organ.
It really is. And we saw in that PubMed study that our acute emergency healing pathways operate on a completely different biological gear than our daily hormonal maintenance.
The separation of those pathways is just a brilliant evolutionary design.
It really makes you wonder where all of this research is actually heading. I mean, if topical hormones can reprogram the skin's structural aging at the cellular level, and we know exactly how specific cells respond to localized signals, what if the future of dermatology isn't about applying generic, mass-produced anti-aging creams at all? What if, like a decade from now, Your morning skincare routine is just a custom-printed daily dose of biosignals, perfectly calibrated to your real-time genetic data, your localized sun exposure, and your daily hormonal fluctuations.
I mean, we are rapidly moving away from treating external symptoms and moving toward literally rewriting the biological instructions themselves. It's not that far-fetched.
Right. But until that sci-fi future arrives, remember that the diagnostic landscape of your skin doesn't have to be totally overwhelming. You might not have the clean binary precision of an X-ray showing a broken bone, but by understanding the mechanics of how your skin builds, defends, and repairs itself, you can start to read the signals it's sending you with absolute clarity. Thanks for taking this deep dive with us. See you next time.